Okay, so let's continue with this chapter so we can finish it up and move forward. We are finishing up chapter 14. We went over our laboratory testing. Okay, so now we're going to get right into our disorders. So we're going to go over all the different types of coagulation disorders, vascular disorders, all different types of bleeding disorders that can happen. Okay. So first, let's go over what are called our vascular and platelet disorders. Okay, so issues that just target the vessel itself and platelets. Please keep in mind that these things can be what is considered acquired or inherited. So when we talk about something that's acquired, that's going to be possibly through, let's say, for example, maybe medication, maybe a disease process. So patients can acquire these different types of conditions, whereas inherited, as you know, that's more of a genetic situation. Okay, now, the first one we're going to go over is something called vascular purpura. Okay, now vascular purpura, I showed you a picture in the last time we were together, showing you pictures of the different skin lesions, okay, or things that are found on the skin. So keep in mind that purpura is going to be pretty much what we call the patches of Tashea that are present, so they're just larger patches. Purpura, we do have different types. We do have an allergic form of purpura, which comes from an autoimmune process. So what happens here, sometimes the body will go through an autoimmune process in the bloodstream. It would pretty much attack the vessel and cause this sort of situation where it will come out to be a purpura, causing this sort of bleeding tissue. Keep in mind that when we have what is called allergic purpura, that patients can also have itchiness to the skin, okay? Whereas most other purpura don't give that type of presentation, but usually the allergic form can also give it itchiness to the skin. Now, we do have another type called Ehlers-Danlos syndrome, and what happens here, this is a deficiency in collagen and elastin. And what happens when you have a deficiency of collagen and elastin, what is this going to do to the vessels? It's going to weaken the vessels, because we know that blood vessels are made up of collagen, correct? So we know that it's now going to weaken the vessels and therefore causing these people to have an increase of bleeding. Please make sure you know that Ehlers-Danlos syndrome is inherited. This is an inherited disorder. It is not acquired. So some patients are actually born with this. They're born with Ehlers-Danlos syndrome. Okay, it's an inherited disorder. And then you also have patients can go through what is called vitamin C deficiency. Vitamin C deficiency will definitely result in defective collagen synthesis. If you don't know, vitamin C is extremely important for maintaining collagen synthesis. Okay, even as women, as you know, sometimes certain facials, and they have certain facial creams and treatments that do incorporate vitamin C, because vitamin C will help with the collagen to keep the skin nice and tight. Okay, so same situation here. Vitamin C will actually keep the collagen in the vessels, make it nice and strong. But in these individuals that lack vitamin C, they have these very weak vessels, therefore leading them to bleeding. Okay, and then also with aging, we talked about this a little bit already. Keep in mind that with the aging process, along with losing loose connective tissue and everything going south, what happens is, unfortunately, we do start to lose collagen as we age, okay? Hence the reason why, again, with a lot of the beauty creams, they do try to have different things that have collagen in it, or to maintain the collagen, because we do lose collagen as we age. So sometimes elderly patients, again, that you may work with in the future may have bleeding under the skin, and it may not be a vascular issue, but just because of the aging process, they will have a weakening of blood vessels. Okay. Now, they do have a way of diagnosing vascular purpura, and this is a quite unique test. Okay, I've never seen it done. But basically what they do is something called a tourniquet test. And with this tourniquet test, just to explain what happens here, they take a blood pressure cuff, and if any of you have ever taken a blood pressure before, which I think everyone has, but what happens is, you know, when you have your systolic and diastolic reading, so when you're taking your blood pressure, what they do is they actually hold the dial right at the mark of the systolic and diastolic reading. okay, mark pretty much where you're supposed to hear. And when they have that, they actually now look for the presence of purpura to pop up right under in the antecubital space, right under the blood pressure cuff. Never seen this test done. I don't know if anybody has seen it done. But in any event, they'll hold the cuff, blood pressure cuff, right at that moment. Now, what do you think holding the blood pressure cuff right at the mark of the systolic and diastolic pressure readings, what do you think that's doing to the vessel? It's putting force and it's really occluding the vessel right at that moment, okay, where it's supposed to start relaxing, pretty much. So not only is the vessel filled with blood, but now it's like pressure on top of it. So if a person has weak vessels, you're definitely going to see it, okay, by doing that particular test. So if they do have a weakening of the vessels, okay, lack of collagen or what have you, they will definitely have the presence of the purpura that will pop up, okay, right in the antecubital space. And just to confirm, they tell you to hold that reading at 5 minutes. You have to hold that systolic and diastolic pressure readings for 5 minutes, okay, and then you'll see that, yeah, so that's quite stressful. Now, the treatment here, treatments for most of these blood coagulation disorders, and we'll go over the rest of them, it all depends on the cause, okay? So if you know the cause, then you treat the cause. So when you're writing your notes and you get to treatment, how can I explain? It's, for this chapter, it's going to be very hard for me to write questions about treatments, but just understand that the treatment is gauged to the cause, whatever the cause is. Okay, I don't know how to explain it correctly, but you understand what I'm saying. Okay. Now, the next one that we're going to go over is what is called hereditary hemorrhagic telangiectasia, which is also known as Osler-Weber-Reduced disease. Okay, so I know that's a mouthful. Now, make sure you know both names, only because I don't know which one will be on the test, and also in future classes, I'm not sure which one they'll use, so you'll know both of them. So what happens here with these individuals, they do have inherited disorder where their blood vessels are just pretty much thin, weak, okay, now putting them at risk for a lot of bleeding disorders and bleeding issues, such as telangiectasia, repeating bleeding episodes, and so forth. Now, just to give you kind of a hallmark that happens with these individuals do have a lot of nosebleeds. Okay, so this is the hallmark, if you want to jot that down. It's not written here in the slide. But these individuals that have this inherited disorder, they do have a lot of nosebleeds. Recurrent nosebleeds. Somebody that works here, actually their son had this situation. They was diagnosed with this. And what was strange was that they said, oh, it runs in the family, but no one in the family ever had it, so I don't know, a little confusion here. But it is an inherited disorder, okay? Now, how do they treat this? Supportive care with anything that's going to stop the bleeding, and cauterization, definitely, that will help with the nosebleeds, okay, if need be. And iron placement, which will definitely help with the fact that these individuals obviously are losing a lot of blood, so you don't want them to get into a state of an anemia, okay? So keep in mind that patients that do have these bleeding issues, they can now also be at risk for having an anemia as well, okay? So just keep that in mind, depending on how much blood is being lost, okay? And then any kind of laser therapy to the vessels.
I have a question.
Yes.
My brother, he'll sometimes have like 6 or 7 nosebleeds in a day. Would that be like a sign?
It could be that, but also nosebleeds is a couple of different things with nosebleeds. It could be, does he have hypertension issues?
No.
Sometimes it could be the vessels, sometimes in the nose. The nose is very vascular. A lot of people don't realize that. And then also the layer over the vessels is very thin. So sometimes if people have a very thin layer of mucosa in the nose, in the nasal cavity, it can also cause them to have recurrent nosebleeds. So it could be a number of things. It could be, has he always been like that from a child? Or,
yeah.
So it could be that when he was born, or the way his body shaped, that maybe the mucosa is not as thick as it should be. It could be the vessels are an issue. Have they tried cauterization for him as a treatment?
I don't think so. I don't think they've ever like tried to treat it or anything.
Okay, because usually sometimes when people have recurrent nosebleeds, they'll try to cauterize it to cut off the vessels and see if that'll stop it. But if he doesn't have any type of systemic issues going on, then it's something in the nasal cavity itself.
Okay, because he's like 6'5", so is it just maybe because like the skin is stretched out, so it'd be thinner, like you're saying?
It's probably because it could be, I don't know if the skin is stretched out, but it's probably very thin. It's probably too thin.
Okay.
But if there's no systemic issues going on, then it's just something in the nasal mucosa. That's the point I'm trying to get at. So keep in mind that nosebleeds can definitely be from anything. So, you know, in this situation, yes, it can be from inherited bleeding disorders, but if you rule that out, then you have to go to the next thing. Is there any pressure disorders? Because sometimes hypertension can also cause people to have nosebleeds, dependent in uncontrolled hypertension, I'll put it that way. So it's a lot of different things that can cause that issue. Okay, now, platelet disorders. Okay, so with platelet disorders, what are we talking about here? Okay, so number of platelets or number, quality, quantity, okay? And this can also be acquired or inherited, okay, so depending on what the situation is. Okay, so, the first one here we have what is called thrombocytopenia, which we already have heard of before. So thrombocytopenia, we know if a person has low platelet count, this will definitely predispose them to bleeding issues, okay, or more bleeding if there's wherever the issue is. Please keep in mind that we talked about thrombocytopenia in a situation if a person has bone marrow suppression, regardless of what's going on. So say, for example, a patient that has leukemia or any cancer, yes, they're going to have bone marrow suppression and possibly put them in a state of thrombocytopenia. Even a patient that has AIDS, okay, if for some reason they are immunocompromised and it now attacks the bone marrow for some reason and then puts them in a bone marrow suppression, they can also have bleeding issues, okay, because of this. So just keep in mind that thrombocytopenia there can be a lot of different causes of this, okay. Splenic sequestration, sequestration, I can't get that out. You know what I mean. Sequestration. Sorry. Okay, that means pooling. Okay, just to let you know, it just means pooling. And what this means is, when the spleen just gets filled with blood, and the spleen will actually be large and tender, okay, tender to the touch, and filled with blood. When you have this type of splenic pooling, just to let you know, this is common in patients that have sickle cell anemia, and also common in patients that have mononucleosis. So they can have that sort of pooling up, okay, of blood. Sickle cell anemia and mononucleosis. Okay, so how do we detect this? We know that by blood work, okay, if these patients have a low platelet count, prolonged bleeding time, which we already know will definitely tell us that the platelets aren't there or definitely not functioning the way they should, and also peripheral smear. Okay, so again, treatment, whatever the cause is, you have to treat the cause. So here are some causes of thrombocytopenia. Some of these we already went over. So chemotherapy, radiation, we know can cause that bone marrow suppression. Cancer itself in the bone marrow, okay, which we know obviously. Also keep in mind that certain drugs can also cause a decrease in platelet count. And here they're talking about the pooling, sequestration, okay, splenic sequestration, and just a couple of things. So make sure you know this chart. Okay, so let's start by that.
302.
302 in the new book, okay, box 14-1. Now, thrombocytosis, this one's a little different. Okay, so with thrombocytosis, this is an increased amount of platelets. Now, what would be the main problem if we have too many platelets? Clotting. Okay, overclotting, okay, or hyperperfusion. Okay, where now the blood is just clumped up together, or platelets are clumped up together now, decreasing blood flow. Okay, So what will happen here is that we'll have a decrease in blood flow with this. That will be the outcome, okay, of having thrombocytosis. Now they're giving you their platelet count greater than 400,000. I'm not sure if that's the same exact range on your laboratory sheet, but you can confirm that. Okay. Now, transitory, this can be due to stress or physical exercise. So sometimes, depending on what you're doing, if you're, say for example, you're doing some kind of extreme exercise or whatever's going on with your body, and your body is increasing the amount of blood that is actually pumping through your vascular system, then you will increase the amount of platelets, okay? And that's a normal situation, and it's transitory, meaning that once you're out of that state, then your body will go back to normal, okay? And it's only doing that as a compensatory mechanism for whatever your activity you're doing at that moment. Primary goes along with what is called polycythemia vera, or as we know, chronic granulocytic leukemia, which we also know as CLL, okay? Now, the other thing here, I'm sorry, not CML. The other thing here is, what is polycythemia vera? Polycythemia vera, just to let you know, this is when your bone marrow makes too many platelets. So it's sort of like, it's not really, I don't want to say it's an acquired disorder, and it is, I guess you would say, kind of inherited disorder, but it's just something in your bone marrow that triggers it to make extra platelets, and so this will cause this situation of polycythemia vera. Okay, and then we know what CML does. Now, secondary, it can be a response to hemorrhage or disease process, or when a person has a splenectomy. Keep in mind that at any time that your body recognizes that there's not enough platelets or not enough whatever that your body's lacking, it will try to increase it. So this can also be sort of like a response or compensatory mechanism here. Treatment, what will happen here is definitely antiplatelet therapy or any type of cytotoxic agents that's going to therefore decrease that platelet count. Okay, so they can give therapy to decrease that platelet count, or also platelet production, to stop the platelet production a little bit. So just keep that in mind, that that is also treatable. Okay, and that's how they treat it. Reduce the number of platelets with cytotoxic agents. So cytotoxic agents reduce the number of platelets, and then we also have antiplatelet therapy. Okay. Antiplatelet therapy is going to help decrease the production of platelets, or try to stop the production of platelets. And then the cytotoxic agents will reduce the number of circulating platelets. Okay. Now, qualitative platelet disorders. Okay, this one's a little tricky. We kind of have it grouped together. Now, with qualitative platelet disorders, this one's a little strange. But in any event, they do break it down into what is called inherited and acquired. So these all fall under the category as qualitative platelet disorders, okay? So under inherited, you do have something called Bernard-Searle syndrome, von Willebrand's disease, and thromboblastemia. I think we're going to go over each one of these in a second. And then the acquired are definitely going to be from drug-induced, if persons have renal failure or any type of hematologic disease. And again, how do you treat this? You have to treat the cause first, and also at the same time, whatever type of transfusion to give them platelets, okay, to stop the bleeding disorder. Okay. So now we're getting into coagulation disorders. So with coagulation disorders, first thing you should always keep in mind, we're talking about clotting factors here. Okay, so we're talking about clotting factors, what clotting factors are missing, okay, that's causing the bleeding issue. Okay. So the first one we have is hemophilia. Okay, hemophilia is the most common inherited coagulation disorder, although hemophilia is rare. Okay, so I know that's a little confusing, but it's rare, but when we have an inherited coagulation disorder, as rare as it is, it will be hemophilia, okay? Now, hemophilia is common in males, Okay, I think you can know that already. And this definitely results in excessive bleeding, okay, with these individuals because of their coagulation factor that they're missing. Now, hemophilia A, these individuals have a deficiency in factor 8, whereas hemophilia B has a deficiency in factor 9. Now, factor 8 and factor 9, they do have, or I should say hemophilia A and B have two different types of treatments. Okay, so let me explain the treatments here. The way you treat a person with hemophilia A, you give something called a cryoprecipitate, and then also, or they can have the factor 8 concentrate. So they do have a factor 8 concentrate that they can give these individuals. Now, let me explain what cryoprecipitate is. What happens is, if you take plasma and freeze it, okay, apparently when plasma's frozen, it actually retains all of its coagulation factors and everything is nice and healthy, okay, or retain all the nutrients or whatever is supposed to be in that plasma. Now, cryoprecipitate, as you know probably from chemistry, when we have a precipitate, something that comes off of the top, or what you want to say, condensation. So it's a precipitate of that fresh frozen plasma. They can take that precipitate and, I believe it's through an injection, I'm not sure, but inject this into the patient and definitely now give them the type of coagulation factors that they need to treat this, okay? So the precipitate alone is enough to treat these individuals. Hemophilia B, they give them either the cryoprecipitate or they can give them just the fresh frozen plasma all by itself, okay? And now, again, keep in mind, the purpose of having a fresh frozen plasma is to make sure that it in that way it maintains all the coagulation factors there and that treats them. Now, how long can you keep this fresh frozen plasma? What's the, I don't know the whole protocol with that, but that's how they're treated. Okay. Now, von Willebrand's disease. Von Willebrand's disease, this is an inherited disorder. Okay, so please make sure you know that. They give you here autosomal dominant. This is a disorder also of factor 8, much like the kind of, I shouldn't say kind of, but much like the same deficiency as hemophilia A. Okay. These individuals do also have excessive bleeding, and keep in mind that the bleeding can occur also like nosebleeds. They can have a lot of bleeding under the skin with these types of conditions, bleeding at organ sites, so it all depends on where, but they can have a lot of bleeding pretty much anywhere. The treatment here is something called desmopressin, okay, which is very unique to this particular disease process, so please highlight that. Because what desmopressin does, it will actually release the von Willebrand factor. So they can give these patients desmopressin, which will now cause the blood cells, or the platelet, to now release this von Willebrand factor, which they're not releasing to begin with. Okay, yes?
So when they diagnose a person with this, how do they differentiate from this disease from hemophilia A?
With hemophilia, I believe there's some sort of testing, genetic testing that's done, because it is, both of these are inherited disorders. So if you were to look at them clinically, they're probably going to have the same signs and symptoms. But there is a genetic testing that's done to test which one is hemophilia. And usually with hemophilia, and also I think with I don't know much about von Willebrand's, but with hemophilia, sometimes the patients know already, or that they have a family history, and then the person will know, okay, or the child. If the child is born that way, then they'll know. So. Okay, now the treatment with desmopressin again will release the von Willebrand factor, and also factor 7, which will also now therefore help with the whole clotting situation. Okay, they can also give them cryoprecipitate, okay, to also further enhance and give them the clotting factors that they're missing. Okay. Oh, and Humate P. Let me explain what that is. Humate P is a recombinant gene replacement therapy. Okay, it's a recombinant gene replacement therapy. Humate P. Humate P. It's right here. I'm sorry. Humate P It's a recombinant gene replacement therapy. Okay, so these individuals, because it is a genetic disorder, they can do a gene therapy, humane P.
Okay.
I'm sorry, I wish I had a word in here. Okay, now vitamin K. Vitamin K deficiency, we already know which clotting factors are made from vitamin K synthesis. Okay, so we know that there are some clotting factors that are vitamin K dependent. So if a person is vitamin K deficient, they are going to not be able to release those factors, okay, those particular factors. So what will happen here is in infants, they can have bleeding early on in life. Melena is what is called black tarry stool. That's another term for black feces, so to speak, or black feces. Hematuria, blood in the urine, intracranial hemorrhage, and sometimes they could even go into hypovolemic shock, okay, if there's an excess, extreme amount of bleeding, okay, that can occur. So how do you treat this? Vitamin K. Okay, so that's easy enough. Now, same thing with adults. Adults can have an acquired vitamin K deficiency. Number one thing, obviously, through nutrition, okay, if they're not getting the proper nutrients. Also, malabsorption. When we get into GI, you'll see that there are some malabsorption diseases that when people eat certain foods, that doesn't mean that they're in the clear. Sometimes that they can have absorption issues where they're not able to absorb certain vitamins and nutrients. So this can also happen. Obviously, liver disease can also cause people to have issues with vitamin K synthesis, and antibiotic therapy and coagulation therapy. So how do you treat this? Vitamin K. Easy enough. DIC. Okay. This one is, it's a tricky one. Yes, it's crazy. And just by the more like I read about things with this class, I didn't realize how common this is. This is more common than I thought it was, DIC. So I don't want to say it's the most common bleeding disorder, but it's quite common. So this is what is called disseminated intravascular coagulation. Okay, so what does this mean? This is when a person has an acquired hemorrhagic syndrome with clotting and bleeding simultaneously. So you're wondering, how the heck does that happen? Okay, so say for example, and I think I was reading this one time, female gives birth, and after she gives birth, she's hemorrhaging. Okay, so extreme hemorrhaging from the birth, whatever, something happened, okay, and there's hemorrhaging. As much as the body's going to hemorrhage, what do you think the body's going to do? It's going to try to clot it. Just as the same amount of time, much it's hemorrhaging, it will try to do the same amount of thing as clotting. So the person will hemorrhage and clot simultaneously, okay? This is a vascular issue, okay, because the body's hemorrhaging and then it's clotting, okay? And so what happens here is that, please keep in mind, and I do want you to know all of these levels that are listed here. Fibrinogen level and platelet count will decrease. Yes, it will decrease because this person is having an issue with hemorrhaging, okay, or clotting. They're not able to clot. Then they're going to have an increased bleeding time, okay, yes, because they're bleeding. Then we have elevated PT, INR, APT, and D-dimer, okay. Now D-dimer, just to let you know what that is, that's a fibrin degradation product. Okay, so that's a fibrin degradation product, which means that this person is now breaking that fibrin, so whatever that clot that they're actually trying to form, now they're having more fibrinolysis that's occurring, okay, if that makes any sense, which now puts them at a further situation of more bleeding, okay. So, the treatment here is to remove or correct the underlying cause, whatever that may be. This can be, yes.
Is that why they do like hysterectomies for women that are hemorrhaging sometimes?
That could be part, yeah, they could do, well, sometimes they do hysterectomies for, mainly for hormonal, other
So what I mean,
reproductive.
like after birth, and they have.
Oh, after birth, yes.
Right after birth?
Yes, after birth, yes, if they're hemorrhaging a lot, yes, they will have to take it out if they can't, because that's the underlying cause, and that's how they can only control it, if that's the only issue. Keep in mind that DIC can be from hemorrhaging, so like say for example, if a person goes into, they're bleeding out, and they go into a hypovolemic shock. The hypovolemic shock, they can also now have a complication of a DIC, okay, because they're bleeding and clotting at the same time. So this can be a complication of shock, okay, and we'll go into shock next week, yeah, I think next week, which you guys will get the video, okay, on shock.
So do they bleed out like clotted blood?
These patients,
I don't know if I've never seen it done.
all of their clotting factors.
But they bleed out regular blood, not
They
clotting
see
blood.
from every, if you've started an IV on them, they will see from that IV site. They will see from their eyes, they will see from their rectum. It's awful.
Yes.
Because on my LV and NCLEX, I got a bunch of questions on DIC, and one review showed that because all your clotting factors go to the site of hemorrhage,
Yes.
the other parts of your body don't have that clotting factor.
Oh, okay, so
That's
then
where
now you have
bleed
more
out.
bleeding. Oh, okay, got you. Okay.
Oh, so like
Yeah.
the clotting and bleeding at the simultaneously would be like the hallmark of this DIC.
Right, that's the hallmark of it. And what I'm going to do is I'm going to review the book that I have with the NCLEX questions on this, and during the review, I'll go over and make sure that I tell you that information. Okay. I'm trying to think. But yeah, I could imagine them putting this on the NCLEX. I'm just trying to think of the questions that I have on this, but I have to look it up. But in any event, yes, this is actually more common than I thought it was. Okay, so this is showing you here what happens with the cascade. Okay, activation of coagulation cascade. You get the microemboli there, and then the consumption of clotting factors. Okay, and what happens here, just from the microemboli, it will definitely cause vascular occlusion and cause ischemia. Okay, so the organ now is damaged, whatever organ we're talking about. Now, when we have that microthrombi there, it can go into fibrinolysis, okay, from the whole coagulation cascade, which will cause a fibrin to split, which will now cause excessive bleeding, which can lead this person into a hemorrhagic shock, okay, or hypovolemic shock. Okay, and then the last one here is hepatic disease. So with hepatic disease, again, we have to revisit and go back to vitamin K. So remember that this is impaired absorption of vitamin K, which will therefore decrease those vitamin K factors that are involved. So same situation here, they will have the inability to clot the blood normally. So how will you treat this? Vitamin K administration. Transfusion of platelets, you definitely want to give them that because they're low in platelets. And you can also give them fresh frozen plasma or whole blood. Now the clinical findings here, from my understanding, is definitely going to be any type of bleeding under the skin. So all of those pictures I showed you, the purpura, the telangiectasia, all that. And then they could also have bleeding at venipuncture sites, which you were talking about earlier with the DIC. These individuals can also have bleeding at venipuncture sites, okay, with the hepatic disease. And they can also have some GI bleeding. Okay. And we're done.
I'm missing after.
Can you
After
just
31:30,
pause that?
I'm missing all of that. I don't know what happened.
It's serious?
Yeah, I have to go print it.